Good afternoon, everyone. So we're going to talk about the core difference, first of all. Sort of like one of the speakers said this morning, go back to the basics. Even though I'm in private practice, we still have residents who rotate through our clinics with us. And when I pose the question, what's the difference between predictive and prognostic, I get this blank stare. They can't explain this at all. So a prognostic test tells you how is the patient going to do? What's their outcome? What's their prognosis, regardless of what therapy you give the patient? But a predictive test tells you what's the benefit or what's the therapeutic effect of the drug you're trying to give. So we have lots of things that are prognostic, but we don't have very many tests that are actually predictive for benefit. The ones we have, however, are really useful to us in the clinic. So what I thought of as prognostic, tumor size, obviously lymph nodes, grade, age, menopausal status, Ki-67, other assays, those are things that don't predict benefit to extended therapy. So it would be nice to be able to put those prognostic things together with a test that predicts to let me give more personalized care to my patients. So the breast cancer index does exactly that. It's got a predictive component, which is simply H/I. It's a ratio of estrogen-related genes, and that predicts the likelihood of benefit from extended endocrine therapy. And it also has a prognostic component that assesses the individual patient's risk of distant recurrence. And this is late distant recurrence between year 5 and year 10. And so when you put all that together, you're able to have more personalized care for your patient. So the power of prediction is really very clear and very obvious here. This is how the new report is going to look. The current report, if you look at the bottom right-hand side here, just says yes or no. And then there's a number under that that tells you what is the risk of distant recurrence between year 5 and year 10. So if the answer is no benefit, then there's no difference whether they get 5 years or 10 years of therapy. We all know that extended endocrine therapy has the potential to reduce risk of recurrence by about 60%. So the new report will do the math for us. I'm always fine with other people doing math. This tells us, yes, this patient's going to respond to extended endocrine therapy, and we have the ability to change her risk of distant recurrence from 8% all the way down to 2 or 3%. That's a pretty big difference, at least to us, and so that's going to be easier for the patients to understand these things. So BCI is recognized by our national leading guidelines for decision-making in extended endocrine therapy. It was recognized in January of 21 by the NCCN and in April of this year by ASCO. The NCCN clinical practice guidelines for gene expression assays are listed here. Everyone's familiar with the 21 gene assay or the oncotype, and that's what we use to predict benefit from chemotherapy. And it's also prognostic. We know that the Mammaprint is prognostic, Prosigna and Endopredict are both prognostic, but the BCI here is prognostic and predictive of endocrine benefit from extended therapy. So these are the actual verbiage from the NCCN guidelines and the 3 trials that are listed here. Dr. Gotti will be going over with you soon. But we want to say that the H/I patients did have benefit, a significant improvement in disease-free survival when they get that extra 5 years. But the H/I low patients did not get any benefit. The ASCO guidelines are very, very similar. They state that this can be in women with node-negative tumors or node-positive, up to 3 positive nodes. And it doesn't matter what endocrine therapy you're looking at, whether it's 5 years of tamoxifen, 5 years of an AI, or some sort of switching combination. And the ASCO guidelines actually call out the fact that the oncotype, the Endopredict, the Prosigna, Ki-67, IHC4, those don't have insufficient evidence yet to predict benefit from extended endocrine therapy.